session, which is normally an interactive session. I will tell you a story. First of all, I have to declare that a member of the Medical Advisory Board of Pulsion Göttingen. This is a story, very simple story of a man arriving at the hospital, 74 years old. He has a past history of chronic hypertension, COPD, which was not severe, and larynx cancer in remission now. And he had cough and fever for 3 days before coming to the hospital, and increasing dyspnea since the last day before. But when he arrived at the emergency room at H0, he was not very well. He has mental confusion, mottling, crackles, fever, 39 degrees, high respiratory rate, 40 per minute, tachycardia, 104, and very low blood pressure, 69/34, and the mean value was 45 meters of mercury. SpO2 with oxygen, 10 liters, was 90%. So we can say that this patient is in shock. There is no doubt about this. You decide to intubate the patient because of confusion, mental confusion, because of low SpO2, because of shock. And you already gave 500 ml crystalloids. And my question, very simple question, do you initiate norepinephrine at this stage? This is a Q1. Yes, no, or I don't know. Very simple answers.
Sorry, Jean Louis, just to clarify, before intubating or after intubation?
After intubation.
After intubation.
After intubation.
I have a question.
More or less at the same time, yes. You intubate the patient, and do you decide? This is before intubation.
Before intubation.
We can say before intubation. Do you initiate norepinephrine at this stage? So yes, number one, number two, or I don't know, number three. So yes. Yes.
Can I say?
Raise your hands. We have no voting system.
Let's raise your hands. Who says yes?
Okay. Who says no? Oh, we have many people saying no.
So hang on a second, wait for the microphone.
Yeah.
Just remember, that's why I think it's important to clarify, because you say to me...
Before intubation.
Before intubation.
Before intubation.
And I think it's a crucial point here. So do you want to say this? We're about to intubate the patient. Somebody wants to start noradrenaline, somebody no. Who says I don't know, by the way?
Good morning.
I don't know.
Okay.
You, one. Okay.
I think it's too premature to start norepinephrine in its level. It will further increase the lactic acid level in his body. So resuscitate the patient. He needs fluid and oxygen, and wait for a few minutes before you start and push on to noradrenaline. It's too premature.
Okay. Shall we see if anyone wants to comment on this?
I will
Who else said yes? There? Just wait a second, the microphone is coming.
I think the risk of the positive pressure further worsening what may be a relatively hypovolemic state could throw the patient into a sickly change of irretrievable shock. So I would recommend starting norepinephrine first, stabilizing the pressure, and then administering fluid as you think is appropriate.
Okay, I think I'm in sort of agreement with what you said. Has everyone understood what the colleague said? Maybe Jean-Louis, you want to comment on this, or you want to tell us what would be your answer?
No, I can continue and trying to convince you that in this case you need to give norepinephrine.
Do you have the time to put the central line to give the NORAD in between?
Do you need a central line?
Not at the beginning. You can use a peripheral line. It's not recommended. Did you look at the literature?
Guys, I like this, but wait for the microphone. So we speak one at a time. Go on.
This is an interesting question. If you looked at the 3 studies that were presented by the professor concerning the reproduction of Manny River study, about half of the patients in each of those studies received vasopressors through a peripheral IV. And the Harvard Pharmacopoeia, in their own document, Mass General Hospital, says that you can use vasopressors through a peripheral of IV up to about 6 hours. In my own hospital, we've limited it to 3 hours because we figure by then you need some, maybe central monitoring needs to get done.
In the hospital that I work, every patient who comes with this kind of situation, we put a center line in the ER and we start all the anatropes and other drugs that we need to start in those cases.
It's a good thing.
Yeah, it is.
I think in this situation, very, very low blood pressure, you could, and we use every day peripheral line for norepinephrine, and after we change.
But what do you think is more important, to give norepinephrine through a central line or to raise the blood pressure in this moment?
Why the blood pressure is low?
Why the blood pressure is low, Jean Louis?
Okay, I will tell you. My answer is yes. Of course, you can answer, I don't know, no, but my own answer is yes. Why? Because the diastolic blood pressure was 34, which is very low diastolic blood pressure. In general, a low diastolic blood pressure like this suggests a decreased arterial tone, suggests here the septic original shock could be vasodilation due to allergy, due to medications, but in this case it is logically due to septic shock. And also, this diastolic blood pressure should incite to administer vasopressor. And we gave norepinephrine.
Can I also make a comment on this? This is very important. I agree with you on the low diastolic pressure, but to me, the key question was also even before intubation, and some of you mentioned this. I think this patient, if you don't start a vasopressor before intubation with this value of pressure, just with fluids, and fluids they don't seem to be enough, with the increase in transthoracic pressure, you may decrease the venous return on intubation, you may have a crash. So I think intubating this patient, deciding completely without vasopressor, personally, I would feel a bit scared about it. Do you want to comment on this?
I didn't understand.
We have to put arterial line as well on this patient.
So what you're saying is, don't worry about the vasopressor, just put the legs up.
No, I'm not saying that. I'm saying is vasopressor comes after you resuscitate the patient with the fluids. Then comes vasopressor.
But we've given fluids.
Oh, good. Then
We've given fluids, but now you have to intubate.
yeah, then you can start your anatropes.
Okay, so you agree with us. We can start now.
Yeah, but the approach is different.
Okay.
The guys who are learning anesthesia and resuscitation should know their approach. And this is the approach should be. First things first, then comes second.
But go back to the slide, just because I think this, we like to do cases that are real life practice. So we've given 500 mL of crystalloids.
Good.
Okay. Now we are not happy about this. Jean Louis said, I've decided I have to intubate. Do I intubate without a vasopressor or with?
You can use a vasopressor, but without a vasopressor you can do it as well. There's no contraindication.
Well, we can do everything in life, but
Yeah, sure.
but the problems may be different, eh?
Sure.
Hang on a second. Do you want this gentleman first, and then there? I'll give you the microphone.
Also, depending upon what you're using as your induction agent for the intubation of the patient will absolutely affect. If you're using propofol, then the chances are you will make, if I'm talking about a non-anesthesiologist, most non-anesthesiologists are not comfortable using ketamine or something else to raise the blood pressure. So most of the times it's propofol, and propofol vasodilates you on top of this situation already.
Hang on a second, the gentleman there.
This patient, that fluid resuscitation is less, and the urine output is not mentioned over there. That is one of the criteria we can say before starting the noradrenaline.
No, urine output
Norepinephrine.
is not mentioned, of course,
Yeah.
because
But,
it just arrived at the
I think
emergency room.
The fluid
This
challenge
is
is
why.
slightly inadequate. You can give more fluids and see whether the pressure is increasing. Preload, you can increase.
But I think the message that we are giving here is important. 69/30 is not something that we can waste too much time before raising the pressure. So yes, you're right. If we have time, we can look at urine output, we can give more fluids, but the example, we have a diastolic of 34.
You know, this patient is septic. This patient has a low vasomotor tone. It is impossible to restore vasomotor tone only with fluids. It is impossible. So you need vasopressors anyway in this patient. And after you will intubate the patient, you will probably sedate the patient a little bit at the beginning, of course. And so you will need vasopressors. So there is no doubt about this. This patient needs urgently vasopressors and norepinephrine because it is the most recommended agent.
Careful, Daniel is coming now with a question.
No, just to add, I mean, if you just plot blood pressure and cardiac output, you have blood pressure, cardiac output. Here we have low vascular resistance, which is quite obvious from what you measure here. So this means that to increase blood pressure to a level which is satisfactory, let's say 20 millimeters of mercury, you will have to increase cardiac output by 10 liters or something like this, which is totally unfeasible. So that's why mathematically we know that we have to institute vasopressors right away. We may discuss indeed peripheral line or central line, but like in cardiac arrest, I mean, we do not put central lines to infuse vasoactive drugs during cardiac arrest because this is a true emergency, and Jean Louis Vincent already mentioned this in his talk. Shock is a real emergency, and this patient is going to die soon, so we have to do something very, very, very rapidly, and so I think most of us agree that we don't have the choice. We prefer a central line, we prefer fluids, but we have to give vasopressors at this stage, peripherally.
Jeff?
So in Australia, we're very bureaucratic. My name's Jeff Lipman. I'm working in Australia for 20 years now. We're very bureaucratic, and we are process-driven terribly, and you're not allowed to. Some nurse will pick you out if you put norepinephrine or noradrenaline through a peripheral line. So the teaching is you cannot give our first line agent, norepinephrine, through a peripheral line. However, I see no reason why we shouldn't be using epinephrine or adrenaline until you get your central line in. So my teaching is that if you've got the drip in, you can give norepinephrine or noradrenaline if you don't have a problem. But if you're worried, just give epinephrine or adrenaline.
We don't have to give just norepinephrine, that's the message.
I looked at the literature, about peripheral line, and there is not so many data, convincing data, showing that it is very dangerous to give norepinephrine with a peripheral line. Of course, you have to be very careful, you have to be very skilled, of course. Okay, so I don't want to spend all the time with only one slide. We can go.
But can I suggest that we call, do you initiate vasopressor at this stage? And then everyone can use whatever you want. Yeah?
Okay. Okay, so we give norepinephrine, which is the most recommended vasopressor agent at the beginning. So the first take-home message is that during septic shock, norepinephrine should be initiated early when arterial tone is assumed to be low. And for example, when diastolic arterial pressure is low, for example, less than 40 millimeters of mercury. Okay, so now we have some biological variables. Lactate is high, it's not surprising, 4.2. There's some degree of renal insufficiency. CRP is high, not surprising, inflammation. And before intubation, we had pH of 7.25, PaO2 78 millimeters of mercury, PaCO2 42, and bicarbonates 19. What do you think about these blood gases? You have acidosis. Do you think it is metabolic acidosis or mixed acidosis? It is mixed, yes. It's not a question, but it is mixed acidosis. Normally, this patient before intubation can breathe spontaneously. He should have a lower PCO2 in case of pure metabolic acidosis. Okay. Chest X-ray, maybe it's not very well visible, but you can notice two opacities in both lungs, more opacities in the right than in the left, but bilateral opacities. This chest X-ray is compatible with the diagnosis of pneumonia. So, before the question, we had time to insert a central venous line for norepinephrine administration, but also for measuring CVP, which was 10 meters of mercury. We had time to insert the arterial catheter, and the pulse pressure variation was 7%. Thoracic volume was 6 ml per kilogram. PF ratio was less than 200. This patient received propofol. I don't want to discuss about sedation at the beginning. Maybe it was a mistake, but he received propofol and antibiotics, and already 1 liter of saline and norepinephrine at a dose of 0.24 micrograms per kilogram per minute. Lactate was still high 45 minutes after intubation. After intubation, it's not so surprising. And blood pressure was 80/38, a little bit better than before, but still low with a mean value of 52. And the question I ask to you is, which level of MAP will you target in this patient? 55, number 1, 60, number 2, 65, number 3, 75, number 4, and 90, number 5.
So hands up for 55. No,
Nobody.
You're not selling this.
60. Nobody. 65. 75. 1, 2, maybe. And 90. Nobody. I just remind you that 90 is a normal average MAP in normal people.
So don't give us your answer yet.
No, I don't give my answer yet. But you said 75. You said 75. Can you explain why? Why you are different from the other ones?
Wait a second. Can you pass the microphone, please?
I just would like to have a little margin for safety.
Margin for safety. And what's in your mind when you think about safety?
Perfusion.
No, I understand that.
Yeah.
But, if you look at data, if I say 60 to my nurses, they will probably put to 70. So if your margin is thinking that I really want to be sure to be 65, probably you achieve that with 55. But so what's in your mind about safety? What are you thinking?
Well, just in case the blood pressure drops.
Okay, so the argument for 75 is the blood pressure may drop, so I want to be on a higher side. Any other reasons for it? Microphone there.
The creatinine level was elevated, and I think we should address that.
Okay, that's interesting. Do you want to comment a bit more on that?
I would like to be sure that the renal perfusion is okay.
So you are worried about the renal perfusion on this patient. Any other comments on this? Wait a second.
She said he had a chronic hypertension.
This patient has a history of chronic hypertension, so need to keep the higher target MAP up to 75 mmHg, so to hopefully can prevent renal replacement therapy.
So you said renal perfusion plus chronic hypertension.
And margin of safety.
And margin of safety. Do you want to ask the hands up again, or do you want to see what Jean Louis Teboul answered? Does anyone want to change your first answer? Maybe. So, 55?
Nobody.
60? 65? 75?
Little more, yeah.
90? And somebody don't know. Okay, show us.
Okay, just to remind you what I showed already. 65 below 65 could be dangerous. This is a study showing that the MAP under 65 was the best predictor of mortality, meaning that you need probably at least 65. Not only the deepness is important, but also the duration of hypertension is important to consider. Okay. And this is a recommendation of the Surviving Sepsis campaign. They recommended an initial target MAP of 65 in patients with septic shock requiring vasopressors. Just to remind, in this multi-center randomized clinical control trial, we try to compare two levels of MAP. One we called high MAP between 80 and 85, and one we call low MAP between 65 and 70. In fact, we found no difference in mortality, absolutely no difference in mortality. We have a signal, a benefit in terms of kidney function with a high MRP target in patients with chronic hypertension, who represented 40% or 45% of the population. Okay. And our recommendation, Maurizio Cecconi, Daniel Debacker, Jean-Louis Vincent, and others, is to individualize. This is a key word regarding blood pressure and many other things. Individualize the target blood pressure during shock resuscitation. And also to initially target MAP of 65 at least, and maybe higher MAP target in case of history of chronic hypertension. I would have answered 75. Why? Not only because this patient has chronic hypertension, but also because the CVP is 10 millimeters of mercury. And you know that the normal CVP is around 1-2 meters of mercury. Normal, you have probably between 0 and 3. And what is important for organ perfusion is the perfusion pressure. The perfusion pressure is the difference between the upstream pressure, which is more or less reflected by the MAP, and the downstream pressure, which is more or less reflected by the CVP. And in case of low MAP and high CVP, you need to consider the difference between MAP and CVP. So maybe in this case, because of high CVP and also because of history of chronic hypertension, I would have chosen 75. Of course, this is my choice. This is not the truth, okay?
Jean-Louis, don't you think it is a little bit, let's say, premature to go already to a high mean arterial pressure target? You were just at the 52. You didn't even test it whether 65 would be adequate or not. And I mean, the consensus, as mentioned, is initial. Here we are in the fine-tuning if the patient do not respond to therapy. And remember that the ASPHAR trial was not done in the 45 minutes after presentation to the emergency department before fluid replacement. But the inclusion criteria were to be under norepinephrine for several hours, maximum, I forgot the maximum amount, you know better than me, but also to have a fluid resuscitation performed and so on before. So I would argue is that in my mind, these kind of patients, I would go for 65, optimize fluid replacement based on several indices we may discuss later on, and then perhaps if the patient is not passing urine, we do not know what will occur when the patient will receive enough fluids and enough cardiac output, then perhaps discuss the increase in blood pressure target at that point only.
I don't disagree with you. Simply just to notice that 75 is not a so high MAP, you know. It's not so high MAP. It is more or less the diastolic blood pressure of normal people. So this is not very high. But I agree with you. We can try to reach 65 first and look at what happens.
Daniel, I agree with you on the initial target of 65. However, do you think that with a higher CVP, your target may change? I mean, on the timing and the study, I agree. You're right on that. I just wonder whether a higher CVP may change things because you start to think more about the difference, of course.
Not with the level of 10, because the level of 10 is, by the way, the level that most of the patients have. So, because statistically, we have seen in the Varpula trial and so on that indeed 65 was a cutoff. In this trial, also 10 was the average CVP they had. I think if CVP was 20, 25, then things will be totally different.
Okay.
Any other comments or questions on this?
One thing I would like to comment is this patient, after 45 minutes, is very poorly resuscitated.
Is?
Very poorly resuscitated.
You're doing a bad job.
I know.
Unfortunately.
This is why the story is not over.
45 minutes, his blood pressure is still low.
Yes.
So why?
I agree. I
Why?
agree.
So it's
You
very
know some
poorly-
patients. You know that
he's-
some patients die.
Yeah.
You know this?
His resuscitation should
This
be
is unbelievable. But some
because
patients
the
die from
first
sepsis.
hour is very important for these patients. So that is the golden hour.
I know. This is why I present this
So
case.
he's
Otherwise,
fully resuscitated. I'm
yeah.
sorry.
But to be honest, in real life practice, 45 minutes go very fast. Huh?
That's true,
We've
that's
been talking for 30 minutes now.
Yeah, that's true.
A question, yes. Please, the microphone.
Afterload in the heart is concerned?
The afterload of this patient is represented by the systolic pressure. Systolic arterial pressure is a reflection of afterload. This is the afterload, more or less. Systolic pressure is only 80. Probably this patient has a systolic pressure of maybe 140 in the normal life before being sick. So I think that afterload is low. If you increase a bit systolic pressure, you increase by definition afterload, but not at a high degree.
But you're also assuming that the ventricular function is in the pre-sick state. In other words, the ventricular function could be changing because of the septic phenomenon.
Yes, but
So
I
then-
assure you this morning that norepinephrine in this kind of situation, when administered early, can improve contractility.
Yes, but it's not just contractility. Venous
I know.
return has to increase, and the increase in MAP and the increase in the mean systemic pressure is not enough an explanation. Either you're redistributing in fast time constants, or tone is increasing and resistance is not increasing, which is the most likely mechanism that norepinephrine supports an increased cardiac index.
But remember, if I can add a comment on this, that in the vasodilatory phase of shock, when you start a vasopressor, you're not just raising arterial blood pressure by increasing afterload, you're also recruiting stress volume. So one of the most beneficial effects of vasopressor in this stage is that actually you're recruiting stress volume and therefore you're increasing your cardiac
But
output.
it can't simply be stress volume, otherwise phenylephrine would be perfect to use. Because phenylephrine will increase the mean systemic filling pressure based on offsetting from unstressed to stress volume. There also has to be a concomitant lack of change in resistance, because all the other vasopressors will cause an increase in resistance. Though the mean systemic pressure increases, the net effective venous return is neutral. So the unique thing about norepinephrine is that it's supposed to increase tone, but not resistance, as defined by 1/R2.
But remember that phenylephrine may work in the very first stage of this by increasing your stress volume and by recruiting. Then it would be a bad drug to keep for the long term because of your microcirculation and all the other problems.
Agree, but again, resistance increases with phenylephrine.
Any other comments, Jean-Louis?
Yes.
A comment there? Yes, I don't believe that when you give a vasopressor at this stage, the largest effect is the inotropic effect of norepinephrine. I think the largest effect is that you're recruiting stress volume into the system, therefore your venous return increases. And then the afterload question is important, but remember that the afterload is so low here that restoring some afterload may even increase the perfusion by raising the diastolic blood pressure and by improving the coronary perfusion. So you may get a benefit on the heart from that as well.
Okay. So, at this stage now, okay, you can target 65 if you want, 75. What do you do in terms of treatment? First, infuse fluids first and reassess, of course. 2, increase the dose of norepinephrine first and reassess. Number 3, do both at the same time and reassess. Number 4, dobutamine and reassess. And number 5, nothing else. You are very happy.
So, infuse fluids first. Hands up. Noradrenaline dose first. Okay? Both at the same time. Dobutamine, nothing else. And from the guy that invented the concept of fluid responsiveness, you've not given us a lot of data.
No, I would have answered, okay, it's not the truth. I would have answered first norepinephrine, increase norepinephrine, and reassess after, just immediately. I understand to do both, fluid and norepinephrine. Again, I am sure that vasomotor tone is low. I am sure that I have something to do with vasomotor tone. This is why I answered norepinephrine. Because again, diastolic blood pressure is low. Because this patient is poorly resuscitated. What do you do in terms of hemodynamic monitoring at that time? This is a multiple choice question. Echo and calibrated cardiac output monitoring, transpyramidine thermodilution, PA catheter, or nothing more than arterial pressure monitoring. So you can answer different answers. So who votes for echo number 1? I would have said who do not, who does not. Okay, who votes for number 2, uncalibrated cardiac output monitoring? Yes, 1 person. Number 3, transpyramidine thermodilution systems. 1, 2, 3, 4. Number 4, PA catheter. 1, 2. And number 5, I am happy with this arterial pressure monitoring. I don't want more. 1. Okay. I would have answered number 1, 2, or number 1, 3, and 4. Not, of course, both PA catheter and transpyramidine thermodilution systems, but one of them, plus echocardiography. This is what we decided together.
Can
with,
I just
yes.
ask a question? It's just out of my interest, because years ago this would have been different, but most of you answered echocardiography. So hands up if you want to have an echocardiography examination. Are you all able to do it or to have it immediately in this patient, in this moment? Hands up. So half of it. Because I think that's a very important concept. To get an echo, it's point of care testing to me in this case. Either you do it now, or to do it in 2 hours or 3 hours is not the same thing.
In this paper with Maurizio, with Jean Louis Vincent, Daniel De Backer, and others, we proposed initially to perform clinical examination, of course, to insert a central venous catheter, to insert arterial catheter, to measure lactate, to follow the changes in lactate, and also to perform as soon as possible echocardiography, because it can give you a lot of important information about the cardiac function. It is the best tool for assessing cardiac function, as said by Daniel De Backer this morning. But we said, if the patient has a severe ARDS, maybe we can also add some more sophisticated, advanced hemodynamic monitoring devices. And either transpyramidine thermodilution system or PA catheter. And if the patient has no ARDS, in this case, he has already ARDS. He has no ARDS, you can give a treatment in function of all the pieces of information you got. And if the patient responds positively to this treatment, you can continue with the same monitoring. If the patient does not respond or insufficiently responds to this treatment, you have also to go to some advanced hemodynamic technology. So in this case, the patient did not respond to the initial therapy, but also had ARDS, so I think he needs to have something more than echocardiography, probably either transpyramidine thermodilution or PA catheter. Okay? So the first take-home message I gave. The second take-home message is when shock persists in spite of adequate initial therapy, arterial pressure monitoring is not sufficient, and some advanced monitoring should be considered. And again, this comes from this consensus conference report with Maurizio Cecconi and also with this expert panel paper. So we perform echocardiography, and finally the results are more or less normal. I can say normal or almost normal. In spite of the COPD, the right ventricle was almost normal. Okay, so
Jean-Louis, can I ask you?
Yes.
Going back to the afterload question, this is the ejection fraction with the 80/40 of blood pressure, or when you restore the blood pressure?
This is at the time we perform echoes. So we had I don't remember exactly the number we had, but it was still low. Systolic pressure was still low.
Do you think ejection fraction, and I'm asking the question to you and to Daniel, it's an important parameter it's an important variable to look at in these patients? Yes, if it's very low. If it's high, how do you use it in your management in these cases?
First, I look at the arterial pressure at the same time, because I cannot interpret LVF without afterload, of course. For example, if I had here 50%, I would say there is some myocardial dysfunction, because 50% is not very low, but a little low, and also because afterload is low. This probably means that contractility is already a little altered. Not in this case, but in case of 50%. So I look at LVF if I also interpret LVF with respect to arterial pressure, of course.
Well, I mean, I totally agree that ejection fraction is an integrative variable. I mean, Robotham nicely showed this a long time ago in anesthesiology. I mean, that indeed it is influenced by afterload and preload. So the three factors are confounded. Admittedly, most of our indices of contractility we use at the bedside, including, of course, those of PA or transport modulation, are affected by afterload and preload. So the true indices of contractility are very difficult to evaluate at the bedside. And at the end, my point of view is that the interest of the ejection fraction is it reflects the actual way the heart is with the intrinsic contractility coping with the afterload and its actual preload. Regarding these values here, 70% is probably even hypercontractile. So I would be looking very precisely whether or not we have signs of left ventricular outflow tract or intraventricular obstruction, because this may occur. It has been shown by the group of Michel Slamas that it occur in 1/3 of the patients at this stage of their resuscitation phase, and this would be an argument to give more fluids, whatever the indices of fluid responsiveness are, because indeed giving more norepinephrine or even the butamine could be detrimental in these conditions.
So this is an important, is ejection fraction an integrative indice that can be compared to cardiac output? Now you said preload and afterload, but you've negated heart rate. And we know in patients with septic shock from earlier work that they maintain their cardiac output or increase it based on heart rate to some degree. So can ejection fraction be used equatably with cardiac output as an integrative indice?
It is an integrative indices. I mean, but it provides different information. I mean, so we need to look at both aspects. As I show in my talk this morning, I mean, you may have patients with, like this one, probably low cardiac output and preserved ejection fraction. And this provides important information as the way you will treat your patient, because indeed, when cardiac output is low, we do not have a lot of options, sometimes fluids depending on other factors or anthropic agents. And having such a high ejection fraction, I don't think that anthropic agents are the solution. So it's either fluids or maybe somewhat manipulating heart rate, but very cautiously, probably at this stage of very low blood pressure and so on, a high lactate.
I would argue against looking at left ventricular ejection fraction or right ventricular ejection fraction in acutely ill patients. Let's leave it to the cardiologists in their outpatient office I mean, ejection fraction is just stroke volume divided by end diastolic volume. The tissues don't care about the end diastolic volume. The tissues in the periphery, they care about stroke volume and cardiac output. A little before, Daniel showed the relationship between ejection fraction and cardiac output. It doesn't make sense. Cardiac output is stroke volume times heart rate, and ejection fraction is stroke volume divided by end diastolic volume. You have stroke volume on both sides of the equation. So the tissues are interested in stroke volume. If you focus on the heart, if you want to know how the heart functions, okay, you can look at end diastolic volume as well. But if you are concerned about tissue perfusion, it's stroke volume that counts. There are people walking in Hong Kong with a low ejection fraction. We should not correct it by itself. There are people in our ICUs with low ejection fraction who do not need any inotropic agent because the tissues are still relatively well perfused. And actually, it may be the other way around. If the tissues are well perfused, you may even consider, stopping the vasoactive agents or even giving perhaps beta-blocking agents in some patients after surgery or with coronary artery disease. So we should not focus on ejection fraction, that's my point.
Yes, but once we have identified, and this is the case here, with a patient with high lactate level, low blood pressure and so on, that indeed the tissues are not happy, the question is to know how to make the tissues happy by providing more flow. And the question is there, should we give volume or should we give inotropic stimulation? And there is where the ejection fraction is the simplest way to look at how to manipulate the cardiovascular system.
The question that I had, maybe I wasn't too clear before, is also when is the right time to look at ejection fraction? If you have a patient with a systolic of 60/30, he may be falsely reassuring you to see a 70%, but by restoring the afterload, maybe you unmask that there is a problem with that. Even though the study by Jean Louis showed that even with norepinephrine, you were able to maintain ejection fraction by raising the afterload. So I think the relationship is very complex. The message is if it is very low, you have a problem. If it's normal, I think it's very difficult to interpret unless you know what is
Nevertheless,
the
in
balance
this case, we can say that the cardiac function is globally okay. And this is not the first thing we have to treat, of course. So I will show you now what happened. So he received saline. We are 60 minutes after intubation. We doubled the dose of norepinephrine, 0.48, and we have the same ventilatory settings. Now the blood pressure is better, not 65, but 63 meters of mercury.
Lower the transducer a bit.
It depends on the transducer. This is a very important comment, CVP is still 10, PPV is still 7%. Now we have a PICO, so we have SVV 8%, cardiac index was 3.1, and we have the PICO variables. This GDVI is a measure of global cardiac preload, which is in the normal range. Extravascular lung water was 11, a bit high compared to the normal range. PVPI is a index of lung permeability is 4, the normal value less than 3, so probably has some alteration of capillary permeability. We are not surprised. We are in the case of pneumonia with ARDS, so it's not a surprising result. And CFI, it is a measure of cardiac function. It is a cardiac function index is normal. Okay, so we also measured SCVO2, in spite of the recommendation is to not to measure. But I like SCVO2, and I like SCVO2 when it is low. And SCVO2 is very surprisingly low in this case, 53%. And hemoglobin concentration was 11, okay? SaO2, I did not give you SaO2, but SaO2 is maybe 90, 93, 94, 95%. It's not the problem. So my question is, maybe not multiple choice, maybe single choice question. What do you do now? Fluid first and reassess, increase the dose of norepinephrine first and reassess, do both first and reassess, dobutamine first and reassess, or I need more information before giving my decision, making my decision.
So, hands up for fluid first and reassess. Increased norepinephrine first and reassess. 3, do both first and reassess. Dobutamine first and reassess. 1 only. Need more information.
So it is very well
You confused us properly with this one. This is a good one. I can't even spot which one is there. I would say 5, but...
When you say, people who said, I need more information, what is the information you want to have?
I think you're almost there. You can rephrase that question.
Has any more fluid been given after the last 1,000 ml bolus? Because 60 minutes have been done between the intubation. What is the fluid been given?
1 liter.
So on top of the previous 1.5 liter?
No,
So
no,
we
no.
are
It is
at
the total volume was 1 liter from the beginning. 1 liter from the beginning.
So this patient had only 1 liter of fluid resuscitation.
Why you
so
said
far.
only? Why you said only?
I'm just asking.
It
because
is a
I don't
lung
know.
infection, pneumonia. He was not dehydrated before coming to the hospital, or very little. It's not an abdominal sepsis.
Sure.
So it is, maybe it's not enough, but 1
But
liter
it's a-
in
but
1
it's a-
hour.
But it's, I think, only, it's a question that many people would ask.
You need more fluids.
Yeah, he's
Okay,
in
so you answered number 1, if you are.
I will answer number 3, but theoretically I'm saying he definitely need more fluids.
Okay. So what is the reasoning now? What is the most striking result here? It is SCVU2, which is 53. So, could be either contractility, but we just saw that contractility was not the problem, or insufficient preload. It's not a problem of afterload, of course. It's insufficient preload. So I am almost sure, like you, that preload is not sufficient in this patient. The problem is that I already gave fluids, he has some ARDS, and I have not the certainty of fluid responsiveness in this patient because PPV is 7%, but tidal volume is low, so we cannot conclude, of course. So when I say I need more information, in fact, in my opinion, I would say just a test to be sure that this patient is fluid responsive.
Daniel wants to make a comment.
I fully understand that you want to make tests to ensure the patient respond, but if you look at your data, what are really the potential alternatives to improve the flow of your patient? Because indeed, as you mentioned, you have echo and other things mentioning that the dobutamine is not an issue. Giving more norepinephrine will not improve tissue perfusion at this stage. You have lactate, which is at 4. It was at 4, it stays at 4, so there is no sign of any decrease in lactate. We have very low SVU2. So all these factors are pointing out that the cardiac output, even though somewhat elevated, is not enough. So
I totally agree.
What option do you have apart fluids? You have nothing. So why don't you just give fluids?
I totally agree with you. The only issue, I totally agree with you. This is my reasoning is exactly the same. I told you. The problem is that if you give fluid and the patient dies, maybe if, I don't know, if the family attacks you, you have no proof of fluid responsiveness. And you can make tests which takes less time you had for commenting this. And for example, okay, I will skip this. For example, because just say we cannot use PPV and SVV in case of low tidal volume.
Can I just maybe go back to the PPV and SV because I think that's an important comment. The tidal volume is 400. So you're saying I cannot trust the PPV and the SVV.
Yes.
But what if the PPV was 15 with the tidal volume? Do you want to make a comment?
Of course, if PPV was 15, in case of low tidal volume, it means that probably the patient is fluid responsive. But here I have no certainty. This is a paper by Daniel de Backer, the guy who commented this question, showing that in case of normal tidal volume, PPV is good, but in case of low tidal volume, PPV is not as good. Also, a study we did showing that with compliance of the respiratory system, which is normal, PPV can be good to predict fluid responsiveness, but when the compliance is less than 30 ml per centimeter of water, it's not. Okay, so in this case, we cannot interpret PPV and SVV, I agree, because of low tidal volume and low compliance, which is only 20. So what to do? We can propose, and it takes 1 minute. So this is why I said it is less than lower time just to compared to comment. Tidal volume challenge, it has been proposed by Sheila Mayatra from Mumbai, and to increase tidal volume for 1 minute only and to look at the changes in PPV. Increase from 6 ml to 8 ml, only 1 minute. And at 6 ml, PPV cannot predict very well. At 8 ml, it is better. And what was better, still better, was the changes in PPV from 6 to 8 ml per kilogram. And the cutoff value we found was 3.5%. In this case, it was 7%. So if PPV increases from 7% to 11, for example, you can assume that the patient will respond to fluid administration. And also, we can perform passive listening test. I will go very fast to say that this test works in case of mechanical ventilation with spontaneous breathing activity, and also works in case of low compliance of the respiratory system, as it is the case here. So the third take-home message is that we can use continuous and real-time cardiac output, but also PPV monitoring. And this allows performing dynamic tests such as tidal volume challenge and passive lag breathing test to predict fluid responsiveness. In this case, we did both tests. And PLR increased cardiac index by 18%, confirming that this patient was fluid responsive. And the tidal volume challenge was performed, and the delta PPV was 5%, again confirming that this patient was fluid responsive. Now we have the certainty that the patient was fluid responsive, and of course we gave fluids, and SCVO2 went up to 69%. Yes, there is a question.
A question there?
Once again, how to do the tidal volume challenge and then test with the pulse pressure variation to check the fluid responsiveness? Sorry.
When you increase tidal volume, you can expect an increase in pulse pressure variation, especially in patients who are fluid responsive. This is the hypothesis we had. Because when you increase tidal volume, you increase the intrathoracic pressure. How much? 2 ml per kilogram. In this example, in this study we did. Of course, this study needs to be confirmed by others. But it is only one study. Yes.
Jean Louis, can I be a bit provocative here? If you do a test, the test can be positive or negative, and there is no test that is perfect.
So if the tidal volume increases...
Let's say that the passive leg raising was negative here. For me, we were still in the initial salvage phase of this patient, where the risk of not giving fluids, if he needs fluids, I think is higher. Why not just doing a small fluid challenge here anyway to see, what was happening?
Okay, why not? It was just to have the certainty, the proof that the patient is fluid responsive. But of course, from SCVO2 and the same reasoning we did with Daniel, it was necessarily due to insufficient preload. Yes. Yes, it is. Yes, it is. Yes, it is. Probably less than 1 minute is enough. 30 seconds is enough, yes.
So if the tidal volume increase and then pulse pressure variation increase, then that means fluid responsive or not responsive?
No, if PPV increases by more than 4%, 3.5%, 4%, this means that the patient will respond to fluid administration. If PPV increases by less than 3%, this means the opposite.
I see the first author of the paper in the back there. Maybe she wants to add any comments practically how to do it. I'm putting you on the spotlight, Sheila. You explained it very well.
Thank you very much, Sheila. So we continue 6 hours later. 6 hours later, not just after. 6 hours later, this is a life of intensive care. You know, this is what we live every day. There was a sudden deterioration of the situation, and now blood pressure is again 52 meters of mercury, the mean arterial pressure. PPV-SVV did not change. What was striking is the increase in lung water, 22 ml per kilogram, and the increase in PVPI, 7. And also SCV2 now is 80%. And norepinephrine is 0.48. Nothing changed in terms of tidal volume ventilation. We perform again tests. The tests were positive. PLR was positive, and tidal volume change was still positive. And my question is, what do you do right now? Fluids, dobutamine, increase the dose of norepinephrine, add vasopressin, add epinephrine.
So, fluids. 1. Dobutamine. Maybe? No? Increase norepinephrine. Add vasopressin. Epinephrine. You confused us again.
This is a difficult case, of course. I think that the two possibilities is either to increase the dose of norepinephrine, this is what I would have done, or to add vasopressin at this stage. This is my answer. What happened, in fact? It was not due to the administration of fluids. What happened? The elevation of lung water and also of lung permeability probably was due to some new septic episode with inflammation in the lung. It is confirmed by the high SCV2, which is a marker of alteration of oxygen extraction capacities. So probably in this situation, we have to deal with fluid would be very dangerous.
Jean Louis,
yes.
Maybe you said that I missed it. I would definitely redo an echo now on this patient. If something like this happened, because maybe cardiac dysfunction is becoming a problem that wasn't before. So
yes.
I didn't know if answering the dobutamine or not, because I thought maybe you give us more information.
You are right. If you trust CFI, which is something indicating the cardiac function, it is okay. But you can redo an echo, and the echo at that time did not show any deficit in contractility. So I said that fluids could be dangerous in this situation, not only because lung water is high, but also because permeability is high. It is 7, which is a very high value. And 7, if you give fluids, probably the majority of the fluid infused will go directly to the lungs. So logically, because again, diastolic blood pressure is low, 39, it is logical to give a vasopressor to increase vasomotor tone, either norepinephrine or vasopressin. Yes.
Just a very naive, maybe provocative question. I understand that permeability is high.
Yeah.
You have fluids in your vascular system. You understand you are reticent to give more fluids. But what occurs to the fluid actually present in the vascular system? Don't they leak because of the permeability which is increased? Don't they already, I mean, you don't do anything. You just keep like this with a CFI of 7. The fluids already present in the vascular system will leak. This is the principle beyond the indice. So at some point, you will end up with more fluids in the lungs, even without doing anything, and less fluids in the vascular system. So is it really at some point a contraindication to give fluids, or is it just a warning that fluids may be dangerous and that if you have some other possibilities, give another possibility? But given all the numbers you give, is it really the permeability which is high, which is a contraindication to give fluids, or is it some other indices that you may perhaps doubt that tissue perfusion is impaired in this patient?
When I look at the arterial blood pressure, I would say that it is not enough, 52. And away, so I have to look at this first, hypotension, and because again, the vascular tone is low, I would prefer to give vasopressors, of course. In addition, I think that fluids could be risky, but there is a logical decision to give vasopressors, either increase the dose or add vasopressin. This is another story.
That's why I wanted to ask. I mean, extravascular lung water is an indicator, but really functionally, unless you start seeing a deterioration in your oxygen status, does it really indicate anything? Because as Dr. DeBaker says, you're going to be leaking fluids. So is it really, I mean, unless it's amazingly off the charts, is it really an indice that we should really be, if we had the availability, is it really an indice we should be following?
But on the other hand, I would almost argue the opposite, because I don't use it very often in the early phases, because I found that extravascular lung water often comes a bit later when you're already out. So when he's out, I would agree that you have a problem here already.
The problem is in the lungs now. You have a PF ratio which decreased from 190 to 100. Lung water is high, PVPI is high. I think that we have to look first at the vascular tone and to try to increase vascular tone. Just to remind you that the maximal value of extravascular lung water was in the study we did with Mathieu Josiac and Xavier Monet, an independent factor associated with mortality. So it is important to take into account. And also PVPI also was an independent predictor of mortality in this study. So what about drugs? As I said this morning, either you can increase norepinephrine or you can add vasopressin. Maybe some people prefer to add vasopressin at this stage to decrease or to not to increase the dosage of norepinephrine. And epinephrine, you like epinephrine. You like epinephrine. I don't know why, but you like epinephrine. But there is a weak recommendation about giving epinephrine with the intent to raise MAP. So I show you this morning, there is no consensual definition of what to do and what is a refractory hypotension. And again, some people think that we can increase the dose of norepinephrine, and this is my opinion, but I accept every opinion about this. So we increase the dose of norepinephrine from 0.48 to 0.84, and now things were doing better. Blood pressure was better, say 75, okay. So the fourth message is estimating lung water and permeability may prevent fluid overload. And finally, my last slide, 36 hours later, so 2 days later, more or less, again, a new deterioration of the situation. Blood pressure went down, and now we have a low cardiac index, 2.4. We have a lung water of 20. The fluid responsiveness tests were negative. And now we have, PCO2, SCVO2 of 70%, lactate still high, and delta PCO2 of 9 milliliters of mercury. I just remind you that normal value is less than 6. So my question is, what is the most likely hypothesis? What happened? Now, hypovolemia requiring fluids, cardiac dysfunction requiring dobutamine, depressed vascular tone again requiring increasing the dose of norepinephrine, all three mechanisms requiring the three treatments, or this is a normal hemodynamic status.
You finished the options.
So who votes for number one? Hypovolemia, typical.
Hands up.
typical profile of hypovolemia? Hands up, please. Nobody? Who votes for number 2, cardiac dysfunction? Who votes for number 3, depressed vascular tone again? 1. Number 4, all 3 mechanisms. Okay, 1 person, and she's normal hemodynamic status. Of course, the answer is number 2. You have a low CFI, 2.9. You have a high delta PCU2 and a low cardiac output, meaning that probably cardiac output is insufficient because delta PCU2 is high. You cannot rely on SVU2 because you have some alteration of extraction capacity, so you cannot rely on SVU2. In this case, it is better to rely on delta PCU2. And CVP is 15, so high CVP, consistent with a good diagnosis of cardiac dysfunction. Of course, you should perform echocardiography to confirm and to find the mechanism responsible for this cardiac dysfunction. Yes?
Sorry. Barring the hemodynamics, the lactate of 4 is concerning to me at 36 hours. Now, if I look at the prognostication of this has a high indication of mortality.
Yes.
And that is of all the things, is what is of most concern for me. So, am I looking at a clearance issue, or am I looking at a perfusion issue? At 36 hours, it has been argued that it can go from type A to type B. But I would still assume that it may be a perfusion issue and therefore want to increase perfusion. So therefore, that becomes the strongest argument for me to look at increasing the inotrope, assuming that we have given enough fluid, and we obviously have given enough fluid.
So what you're saying, if the lactate was normal, I wouldn't care about increasing the perfusion?
No, well, the blood pressure is still low. I would care about that. But I'm saying the lactate is particularly concerned.
Okay.
One question there?
I was wondering, there's also already a tachycardia, and you're suggesting to give dobutamine. Why wouldn't you give a phosphodiesterase blocker or something?
Phosphodiesterase inhibitor instead of dobutamine, you mean? It is an option. The problem of phosphodiesterase inhibitors is it is a strong vasodilator. So you need to increase the dose of norepinephrine or to give another vasopressor.
You can still get some tachycardia and some arrhythmias even with those anyway.
Either way, you have to pay a price. And which price is bigger? The price of dobutamine or the price of your vasopressure?
What's the highest price? I tell you why my managers tell me what's the highest price.
There is a question. Yes.
Well, if anything, I would begin with the butamine just to have a drug which is a short half-time and to test the system. If indeed there is an improvement in hemodynamics in terms of response in cardiac output and other things, and an improvement in the PCU2 gap and whatever, lactate, then indeed, if you are concerned with tachycardia, you can switch to phosphodiesterase inhibitors later on. But the risk is really if there is no recruitment of the cardiac output by inotropic stimulation, and you give a phosphodiesterase inhibitor, you are stuck with 6-8 hours, especially with this patient who has renal replacement therapy. So that's really the risk for this. Levosimendan can be the other, but very costly and also a very long half-time. So it's
question.
Other questions? Or? Yep.
The microphone is coming.
So, if I use dobutamine, the general teaching that I understand is that if it increases the heart rate by more than 15%, then I may be trading cardiac output for myocardial ischemia. So, just the baseline tachycardia in and of itself at this level, I don't think represents contraindication, but an increase in heart rate with the use of dobutamine may indicate increased myocardial oxygen, problems with myocardial oxygen consumption. Is that correct, or is that
No, you are correct, of course. You are correct. But this is a very difficult situation you have to deal with. You have to do something, and in this example, cardiac dysfunction happened. So what to do? Either you do not treat. Of course, you can respect cardiac dysfunction, but in this case, because we have high lactate, high delta PCU2, I think that we need to, and proven cardiac dysfunction with echocardiography, of course, I think we have to do something. We have to treat the patient because the patient is very severe. But sometimes we have to respect cardiac dysfunction if you have no hypoperfusion associated with.
May I suggest, I'm sure you have far more experience in intensive care. I don't work in intensive care. I'm an anesthesiologist. Why don't guys use the intra-aortic balloon counterpulsation? Haven't you used that? It works very well.
What? Excuse me?
Intra-aortic balloon. Yeah, balloon pump. It works
Balloon
very well.
pump.
Yeah,
Oh.
balloon pump.
At that time, we just discover cardiac dysfunction, so we have something to do with dobutamine. After, if things are doing bad, so maybe we have to think about other options. But the first option in this case is to give dobutamine or maybe another inotropic drug, but not balloon pump at that time, really. Jean Louis?
There is hardly any place for intra-aortic balloon counterpulsation in septic shock, and ECMO should be kept for very, very severe cases. We may return to that later.
Yeah, he's reaching there.
Now, I'm afraid that we will leave the case, and I wanted to return to the basics because nobody, I think, spoke about the propofol that this patient was receiving. Why was he on propofol? All the discussion was very nice about fluid responsiveness and everything, but we say that when the patient does not stimulate the respirator, it may be reliable. But allow me to finish, please. So, if we stop the sedative agents, we may lose that type of signal. But that's okay. Don't forget that propofol is a substance that will decrease myocardial contractility and decrease vascular tone. Yeah, it's an anti-dobutamine and anti-noradrenaline. And these patients with shock, as I indicated in my talk, usually are quiet. They are not agitated. They will not go out of bed. There is altered cerebral perfusion, but as soon as you leave them alone, they fall asleep typically. So the nurses sometimes say the patients need sedation because for the comfort. What do you mean for the comfort? These patients are usually comfortable without it. So currently the Surviving Sepsis campaign and everybody else recommends to avoid sedative agents unless it's absolutely necessary. Was it necessary in this patient?
I agree with you, Jean-Louis, and I said, maybe you didn't listen to me, but I said it is a mistake, I think. But it is it was a real case. So I said, I think I would have given propofol. Yes, I said this. Nevertheless,
but also the evidence is coming stronger and stronger for that. But if you see practices at the bedside, very often we see patients deeply sedated.
We see patients, but I totally,
I agree.
I totally agree with you. Totally agree with you.
What we use dexmedetomidine. It's a very safe drug. Dexmedetomidine. It's a very safe drug, and for longer sedation with midazolam, dexmedetomidine works very well. It's not a carbonate disorder. It's not a myocardial depressant. It has no toxic effects, and you can use low dose, no problem at all. Propofol is the last drug to be used in this patient.
I have a question.
It could be a good option,
Jeffrey
yes.
Lippmann, but I want to see if this patient survives. So we need to finish soon.
Can I ask the experts what they feel about ketamine, both for induction but also for maintenance of sedation and pain relief, particularly with the problems that Jean-Louis Vincent brought up about propofol?
Okay, in fact, it is, Sheila, you want to add something?
What Professor Vincent said, that in this kind of situation, really giving sedation is not really a priority because the patient is already depressed. And ketamine is a very good drug for induction, yes, but for long-term use as an infusion, it's not a preferred agent in the intensive care unit.
Okay, thank you. It was my last slide. This patient finally was discharged alive because finally he decided to leave. He decided to leave himself. So thank you very much for your attention. And just my last take-home message is consider PC2 gap to assess the adequacy of cardiac output in case of sepsis with apparently normal SCVO2. Thank you very much.